Good evening, everyone. Thank you for joining. I am Dr. Abanulo for those of you that have not met me yet, and I look forward to hopefully meeting you one day. Tonight we are going to do our 5th Tuesday talk for 2026. And if this is your first time visiting or attending, tuning in, I want you to understand that we do this every month, first Tuesday of the month, and the goal is really to do exactly as we say in this title slide, which is to empower you so that you can go on to empower yourself and empower the world. If you've met me, you know that I'm really passionate about advocacy, and I always congratulate my women for prioritizing their health. Which really leads to well-being and often the improvement of those around them. So we love education, we love resilience, and we love advocacy. So our talk today is actually about vaginal prolapse, okay? So we're gonna go ahead and get started. Okay, so up to 50% of women will have prolapse on exam. So I want you to just raise your hand. I can't see most of you, but if you know another woman, raise your hand. Okay, now only 6% will actually report symptoms. 6%. So I'm gonna give you a second. I want you to go to the chat and I want you to just take 5 seconds to think about this and put in a reason why you think only 6% of us will actually report our symptoms. I'm loving the fact that you guys are responding. Okay, so we've got embarrassment, right? You're going to your doctor, maybe it's your primary care doctor or even a gynecologist, and you're there to have your annual exam. They're listening to your heart, your lungs, and they're asking you if you've checked your cholesterol. And it just seems out of place to be like, well, there's actually a problem in my vagina. It feels out of place and not necessarily welcomed, right? Unaware that something is not normal. Now, we can unpack that, right? I think we often, especially as women, we power through. Maybe you brought it up to someone and they said that you had a baby. That's what this looks like. And so then you go on in life and assume that this is how my life is just going to be from now on. This is what most people probably deal with, and I should just suck it up. Women don't complain. We take care of others and put ourselves last. Oh my goodness, right? That I feel like everyone here can identify with that. Embarrassed to talk about it. Absolutely embarrassed to talk about it. And if you've met with me before, one thing that always comes up is, well, you guys start the sentence like, I wonder why my mom never told me about this. And then you finish your own sentence and say that, well, we're not really trained to talk about it. We don't exactly bring it up at dinner. And, we as women are often told to kind of keep it to ourselves. So there's a lot of embarrassment that comes with it. Okay. So vaginal prolapse, a few things that we're going to talk about today. And obviously, this is a passion of mine, so we could talk for hours about this. So I tried my best to try to keep it within about 30 minutes so that we have time for your own questions and comments, things that might come to your mind. But we'll first talk about what is prolapse. After that, we'll go into what are the causes of prolapse, how we diagnose prolapse. We'll go over the treatment options. And then finally, we'll talk about what the long-term outcomes can be. So, what is vaginal prolapse? Vaginal prolapse is a condition where part or parts of the vaginal wall have come down toward or through the vaginal opening. So I like to think of the compartments as the front, the back, and the top, okay? Now, the vagina has 3 layers of support. The most outward layer is really our levators, our pelvic floor muscles, right? Those are the things that we can improve when we do things like pelvic floor physical therapy. The second and the third layer are our ligaments, and these are more from collagen, fibrin, things that don't necessarily respond effectively to pelvic floor strengthening. And so those ligaments live kind of around the vaginal canal. And so you can have the top come down, the back come down, or the front of the vagina come down and towards that opening. Now, what are the different types? So this is also kind of an insert about terminology when it comes to prolapse. So if the front wall is coming down towards the opening, we call that officially an anterior vaginal wall prolapse. Traditionally, that was called a cystocele. If it's the back wall, we call it a posterior wall prolapse or rectocele. If you still have your uterus, and that's the lowest part of the bulge, then we call that a uterine prolapse. If you don't have your uterus, let's say you've had a hysterectomy, it's a vaginal vault prolapse, okay? And then pretty often, we'll have a bulge of intestines that'll push down from the top of the vagina, and that's called an enterocele. So I have a few pictures here so you can kind of visualize what that looks like. Typically when you come with a urogyne appointment, we like to say that we can show you better than we can tell you. So oftentimes we'll do measurements and we'll kind of put that into a picture so you can see what your actual prolapse looks like compared to normal. So this top one here is where things typically sit. There's our bladder, uterus, vagina, and rectum. When the front vaginal wall comes down, we call that anterior prolapse. You see that back area is the posterior prolapse. And then here you have the top of the vagina coming down. Now you'll hear people say, oh, I had a bladder prolapse, or I had a bladder lift, or I've got a cystocele, there's something wrong with my bladder. When I look in the mirror, I can see my bladder. It is not your bladder. It is your vagina, which has lost one or all 3 of those layers of support. We call those other organs, or I do, innocent bystanders, which means there's nothing wrong with the bladder, and there's technically nothing wrong with the uterus, and usually there's nothing wrong with the rectum. But they are falling towards that point of least resistance. And so that's why historically they were called cystocele for bladder prolapse or rectocele for rectal prolapse. What gets confusing is when my women come in and they say, well, I've got a rectal prolapse. Okay, so a rectal prolapse is different because the rectum itself is coming down through the anal opening. That's a different problem that is treated by colorectal, okay? But you see how just a change in how we phrase something can get you on the wrong path to a provider, right? So if you combine that with just maybe not even having the courage or the encouragement to bring it up, you 7 years later are like, I give up, I cannot, this is never gonna be treated. 7 years is the average time it takes a woman to get from the first time she mentions a complaint about her prolapse to being in front of a urogynecologist. Can you imagine? Like, how do we not give up? We are so resilient, right? So, but understanding the terminology helps for you to advocate better, helps you to explain to someone who says to you, this is part of aging. You say, no, this is a cystocele. This is anterior vaginal wall prolapse. It has a medical term, which means it's got a medical treatment. So send me that referral, okay? All right. What are the causes of prolapse? This is a big question, understandably, that comes up when we first meet here in our office. Oftentimes, as our estrogen levels are dropping, those ligaments that I referred to will lose their integrity. And so they'll often soften and start to weaken over time. And so that's where age plays a role. Prior childbirth. Now you'll notice I didn't say prior vaginal delivery. yes, a lot of research shows if you've had a vaginal delivery, if you've delivered a baby over 8 pounds, if you had a fast delivery, if you had a prolonged delivery, if they had to use forceps and vacuums and you had a big tear, those are all risks for prolapse. But you can also have prolapse even if you ended up with a C-section. It can still cause the ligaments to fail over time, okay? And all it takes is one beautiful baby to do that. So we love them though. Another question that comes up, maybe you've had one kid and you're like, well, how many can I have? Is it going to get worse with each pregnancy? And what we know so far is that we typically see the extent of the prolapse after 2 pregnancies. So if this develops after your second pregnancy, actually, you should always have babies. If you want to procreate, by the love of God, please do. But usually after the second one is when it stabilizes and kind of normalizes out, okay? Chronic constipation. So some of my women are born with constipation that you deal with throughout your lifetime. Or maybe you developed it from a medication, GLP-1s. That's been a real common one that's been coming up lately. Other medications that cause constipation, poor nutrition, poor movement. Maybe there's another reason why you're not up on your feet. Maybe the prolapse has got you not up on your feet. Anyway, when you go to have that full bowel or you're having to bear down or strain in order to have a bowel movement, that can weaken that back vaginal wall and cause a rectocele or full prolapse. Heavy lifting. So this is kind of anecdotal. There's definitely medical evidence, but my personal experience, I did 3 weeks of surgery in Addis Ababa, Ethiopia, and I was teaching the general surgeons, the general gynecologists there, how to do urogynecology. And I was like, wow, you guys have so much prolapse here. And one surgeon explained to me that a lot of the women who can be very short and small in frame would go up mountains with large packs on their back. And so that was actually a risk factor for their prolapse. And they would see these women come down from the mountain, have their surgery, and go right back to work. And so that was really interesting. So heavy lifting. And I used to joke, like, you know, heavyweight lifters don't typically get prolapse because they're trained gradually to do heavier and heavier weights. You do get other issues. So I don't want to say, I don't want to put a kibosh on all heavyweight lifting, just understanding that, you know, 0 to 100, definitely a risk factor. If you're going to pursue heavier weights, I encourage you to work with pelvic floor physical therapy or occupational therapy, and definitely a personal trainer, so that you are not putting your pelvic floor at true risk when you take on these challenges. And then finally, genetics. There's a lot of controversial and kind of mixed evidence about what kind of genes put us at risk for prolapse. And it's really hard to know if it runs in your family, right? Because as we just said, mom didn't talk about it, aunts didn't talk about it. You may not have even noticed it until you were caring for her in her late stage of life, right? We do notice, of course, that women that have Ehlers-Danlos syndrome, right, which is a condition where you have lower collagen count in your tissue, you have stretchy tissue. Maybe you would always joke that I can bend my thumb all the way back. Those women are usually hypermobile. And so their collagen, their tissue stretches very easily. And so this is something for them that can present really early in life without ever even getting pregnant. So genetics definitely plays a role. Okay, so how do we diagnose prolapse? This is actually a slide for my fellow doctors in the community who might be a little upset with me. But number one, listen to her story. Listen to her story. Listen to her story. You know, I just can't stress that enough. Like I said, it takes 7 years for a woman to complain and ask questions. She gets on the computer, she looks it up for herself. And by the time she's met me, she often is like, I've talked to 10 different providers about this, you know. And I think some of you can agree that this happens in multiple issues that we treat in urogynecology, not just prolapse. So listen to her story, get her history. I don't know if you guys have heard history versus herstory, so that's, we'll throw in there. And then after that, you want to be referred to a certified urogynecologist. Okay, so what does that mean? I'm double board certified. I did 4 years of OBGYN, and I went through an additional 3 years of urogynecology, or also known as female pelvic medicine and reconstructive surgery. It's a mouthful. You can also come to this way by urology. Some urologists will do 5 years of residency, 2 years of their urology training. Why is this important? We were not nationally accredited until 2013. And so we're young. We're so young. Like, if you compare us to cardiology, internal medicine, right? These are areas that have been studied since the 1800s. So we're still learning. But what that means is, for those of us that went through official training, we bring more to the specialty, we bring more to the service, we do a lot more comprehensive care, and we have to stay up to date with proper technique and safety. We become the steward of your safe delivery of care, right? In 2019, when the FDA pulled dangerous mesh off of the market, we were saying, yes, please take it away, right? Those are the providers who we hope you were in front of. When we learned that anticholinergics are causing increased risk of early onset dementia, it was urogynecology that was like fighting with pharmacy, fighting with pharmaceuticals to say, no, I refuse to prescribe this. And that started back in 2016, 2017, when the first big study came out. Oh, sure, I will tell you. So that's okay. Anticholinergics actually appears in different types of medicine. But for us, it's oxybutynin, it's Detrol. It's the first overactive bladder medications that were put on market. Worked great, but they cross the blood-brain barrier and can cause early onset dementia. You'll see that in some mood stabilizers. You'll also see that in Benadryl and some allergy medications. And there's some other categories, but yeah. So now we really push for beta-3 agonists, which we now know, well, we have to rigorously study those medications too, because for a long time we thought the anticholinergics were safe. It turns out they were not. So that's what I mean by certified urogynecologist, someone who wakes up every day to provide you with thorough, well-rounded care, while also looking out to make sure that as we start in this kind of pioneer journey, that we're making the best decisions that we possibly can make. All right, once you finally make it to a urogynecologist, you want to complete a thorough physical exam, or exam, I should say. Here we go. Oh, go back. I'm spoiling the show. Okay, so the urogynecology exam, there's 2 main parts. There's a history, so listening to your main concern. I often have women that'll come in and she's like, I just came to talk to you about something falling out of my vagina. Why are you asking me about my bladder symptoms and my bowel symptoms? And then usually by the end, she realizes that it's all tied together, right? They all live in the same bowl. And so, we worry about leakage. We worry about infections, inability to empty your bladder properly, which then can lead to kidney injuries and kidney failure. All of that can be tied to prolapse. We also worry about bowel control. Are we having leakage from incomplete emptying, right? Are we dealing with a lifetime of constipation, in which case, if I rush you to the operating room and do this big surgery, it'll come right back if we don't improve the bowel function. So we really want to do that well-rounded assessment. Then we want to know what the things that are pertinent. Has anyone else been in your abdomen? Have you already had a workup? Oftentimes women will have had, one doctor did a urine study, one did a cysto, one did a urodynamics. We're putting all the pieces together by the time they show up here at our office. Now, for the examination, I like to call it an interactive GYN exam. Sometimes you guys want to start asking me about, like, well, how did you get into urogynecology? And I think part of that stems from like old male gynecologists trying to make conversation while they do your pelvic exam, and you're like, can you just get in and get out, please? Anywho, I'm asking you questions, I'm having you bear down and cough and really give you a chance to reproduce that prolapse. But I'm also looking for sensation. We're looking for reflex, because we want to look for nerve damage in the pelvic floor. That plays a big role in our decision making. We also look for pain. We also look for masses, right? I can't tell you how many people have come in, they were sent for prolapse, turns out they had a mass, they had a cyst, they had a fibroid, right? Completely different outcome than what we showed up for. So the pelvic exam is very critical. We then have you do a urine study. Usually they say, oh, I don't have any urinary, and this just happened yesterday, I don't have any urinary symptoms. Sorry if you're watching this. I only pee 3 times a day. And I was like, okay, we're gonna treat your prolapse. And I went to do her bladder scan, and she's not emptying at all because the prolapse has kinked off her bladder opening. So important. So we do that little bladder scan towards the end before we kind of dive into talking about treatment options. Okay, so what are the treatment options? Here's another big red flag. If you walk into a doctor's office and you say, well, I've got prolapse, and they find the prolapse, and without any education, they're like, what surgery do you want? Right? Big red flag. So there are non-surgical and there are surgical. Non-surgically, there's pelvic floor exercises you can do on your own. These are Kegels. These are also hip bridges, there's Pilates, there's bar, there are programs you can do that specifically target not just your core, but your pelvic floor. I should make a t-shirt that's like, not just your core, but your pelvic floor. Pelvic floor physical therapy. Last month we had Jessica Dorrington come and talk with us, and there have been a lot of advancements in that field. So sometimes when my patients come in and like, I went a long time ago, I encourage you to go back because of the advancements that have been made over even the last 10 years. If we're only 13 years accredited, they are even younger. So as far as their advancements, but a very important part. I will say, like, if I had 10 women that had prolapse and I sent all of them to pelvic floor physical therapy, about 3 or 4 will end up not needing additional treatment, right? So that's almost half of us can have an improvement without needing to undergo a big surgery. And then there are pessaries. So these are silicone devices. They fit in the vagina, kind of like a diaphragm, if you remember those at all. But they push everything back up to where they're supposed to be. If you ever stop by, you should see my pessary museum. We used to make them out of rubber. They used to be made of plastic, glass. They also used to hang women upside down for 3 hours. That was a good time. I want to thank all the women that came before us for all the work that they did. Just so brave. Obviously, hanging upside down does not work to fix prolapse. And so now they're made of silicone. And the reason why we like the silicone is because it has the least amount of reaction. The body has the least amount of reaction to it. And they're getting softer, more malleable, and easier for us to self-manage. I will say, just a quick plug, that half of my patients don't take their pessary out on their own at all. That's usually a big obstacle for women. It requires dexterity, and so it can be hard to do. So if you are someone who's really shy of surgery, but someone said, well, you can't do a pessary because you'd have to take it in and out on your own, I encourage you to seek a second opinion or come by our office. We're happy to help you through that. Now, surgically, there are 3 main options that I offer. We can use your own tissue to do the repair. That's a native repair. We can use mesh. That's called a sacrocolpopexy. Or we can do a colpocliesis, which is a vaginal closure. Okay. So we're going to take a dive here into those surgical options. So I put a little chart here together for you guys. Feel free to take a screenshot so you can save these numbers or the comparisons for these. And I can absolutely send these to you guys. We can send these to you guys if you want them. But of those 3 options, when we use your own tissue, historically, we used to take everyone's uterus out. Just take it out and then use her own ligaments to pull everything up, tighten the front and the back walls. I think it was 2017, 2018, there was a study that came out of the UK showing that you don't have to take out the uterus. They had the same outcomes. Of course, me being American, I was like, I don't believe it. We got to do our way, the best way. Anyway, we did our own studies and it was true. So it saves OR time, decreased blood loss, decreased complication risk. So that doesn't mean that if you want to have a hysterectomy at the time that you cannot have one, but it has cut down on the number of unnecessary surgeries that we've done. So everything's done through the vagina. This is also a great option if you've had a lot of abdominal surgeries. Oftentimes when Goldilocks has been there before, you get a lot of scarring in the abdomen, and so that actually can make reconstruction pretty dangerous. And so this is a great option for that patient as well. Success rate is about 70% in well-trained hands. It's a lot lower if someone has not been formally trained in doing these repairs through fellowship. It's about 2.5 hours in the operating room. And then the next one is sacrocolpopexy mesh. So a really big word, but essentially this is mesh that's being placed from the top in order to pull up that vagina. And I do mine robotically through 5 small incisions, and I have to take out the uterus in order to place it. You may go online and see that some people leave the uterus in. I am always at the forefront of research and technology. We don't have enough data yet to see the safety of that. And so for that reason, I still do what I feel works safely and best, which is to take out the uterus, but try to leave the cervix for this procedure. All right, so 90% success rate, a little bit longer in the operating room, 3 hours. And then the last one is a colpocliesis. Now this is the traditional. This is when, like, 1950s, 1960s is when they came up with this technique. And it's a vaginal closure. So it's a bit of a magic trick. People in the OR are always like, where did it go? And you're basically suturing the prolapse back in, but effectively shutting the vagina. And so you're not able to have penetrative intercourse after you have this technique done. It is the fastest, and it's a 95% success rate. Obviously, this is reserved for women who feel like that chapter of their life is done. On very rare occasions, we'll do it in someone who's a lot older and is not a great surgical candidate, but everything else has failed. Then we'll kind of pursue this as long as her heart is ready for that decision. And all of these have a similar downtime of 6 weeks. And I'm a broken record, so you've probably heard me say 6 weeks, nothing in the vagina, no sitting in water, 10 to 20 pound weight limit, 15 to 30 minutes walking 3 times a day. A little word on surgery. When we're learning that if you can prep your body for surgery, just 3 hours of anesthesia exposure, you have a better outcome. And that prep means for the 2 weeks leading up to surgery, you want to challenge your heart and your lungs every day so that you tolerate that anesthesia, you metabolize it well, and you're back up on your feet day after. Okay. Our restrictions used to be, for the rest of your life, you can't lift anything greater than 25 pounds. And you have to sit still in your bed for 6 weeks, don't even get up. As you can imagine, blood clots, poor healing, and full decompensation, right? Where you're not able to rebound. So now we want you walking the same day. We want you communicating, talking with friends, going out and getting that fresh air. All of these things make a huge difference in the rebound. That 10-pound weight limit that you'll usually hear, people want you to exercise that. Keep those muscles warm and moving. Okay? Okay. What are the long-term outcomes? I kind of put up the most common questions that I get from you guys here. And I'll try to go through them as quickly as I can. Okay, so the first one is, what if I do nothing? And usually what you guys mean by that is like, will it get worse if I don't do anything? And it is really hard to say, right? So let's say you're like a stage 2 out of 4. There's 4 stages. You're stage 2, and by doing nothing, you don't improve your constipation, or you still take that medication, you continue heavy lifting. Yes, there's a good chance that prolapse will progress. Okay. If that risk factor is gone, though, let's say you've got great pelvic floor strength and you're done childbearing, you've got normal bowel movements, nothing else, then, let's wait and see. Let's come back in a year. Let's see how you're doing, right? A lot of times women will come in because their doctor did the right thing and said, hey, there's a problem here. Let me send you. And you didn't know that you had prolapse, right? So now we're here just for education, which is perfect. This is the best time to catch you, because then you feel more empowered to say, well, I've identified my risk factors. I can go to pelvic floor physical therapy, or I can start doing pelvic floor strengthening on my own so I can optimize my outcome. And worst case, I know where to go if something happens. Do I have to repeat the surgery in 10 years? This stems from the research that has been done in reconstructive surgery, and almost all are 10-year studies. And so if you think back to that slide with the chart or with the table, basically those numbers I gave you were 10-year numbers, meaning if you used mesh, for example, at 10 years, 90% of women still had a perfect outcome, no recurrence of prolapse. Okay, so our goal is that 30, 40, 50 years from the time of your surgery, you're going strong and not having to think about this at all. Can I go back to heavy lifting? Yes. So it definitely depends. If you do a native repair, meaning you use your own tissue, and you go back to heavy lifting, there's a good chance it's going to come back. That's just, your tissue has shown you that it doesn't necessarily tolerate that heavy lift. You get a much more durable repair when we apply mesh to the prolapse. With that being said, I strongly encourage you, if you didn't do it the first time, to incorporate pelvic floor physical therapy or occupational therapy in teaching you how to properly lift, understanding what your true limits are. 25 pounds to me is going to feel very different to someone else. And so that might be my limit, but not your limit, right? So learning about what your body can tolerate before that scale is tipping is really important. All right, what happens if my surgery fails? Nothing I said today was 100%, except that if I take out your uterus, it's not coming back. That's the only thing. So if your surgery fails, it does not close the door to repeating the surgery, trying a pessary, or choosing a different type of surgery, right? Those are all still options for you. Is it important that I take care of this? Okay, this is a good one. You have fought for this appointment. You showed up to the urogynecologist's office. You waited 4 months, sometimes 8 months to see the doctor, and you're like, do I really need to take care of this though? You don't have to. And I cannot force you to do anything you don't want to do, right? If nothing else, you leave here educated, and that is empowerment. If you have prolapse that is preventing you from emptying your bladder, we're looking at kidney failure. We're looking at recurrent bladder infections and stones. That is an outcome that can happen if we don't address the prolapse. If you have a prolapse that's making it difficult for you to empty your bowels, then you have worsening constipation. Now we're piling on the different medications to help you have a normal, comfortable bowel movement. But the real ticker is that when we have untreated prolapse, we very unknowingly pull ourselves back socially. And that's actually what led to the accreditation of urogynecology. We had to show the impact on quality of life. So what we found is that women with prolapse had a higher depression score. And that led to other medical problems, right? I mean, you can imagine it. You've got prolapse, or maybe you have leakage, which means you're not socializing as much as you would. You're not going on that walk. You're definitely not lifting that weight. And so the diabetes kicks in, the high blood pressure, the strokes, the decreased bone health. It's a cascade. And so it might feel like something that's on the lower list of things to do, especially when we have our kids to take care of, our husbands, our partners, our parents, right? But meanwhile, it's eating at you, and you may not realize it until you're very far along. So absolutely, it's important to take care of it. All right, and then how old is too old for surgery? This is a very difficult conversation that I have, it feels like every day. And after that list of all the people I just listed, some of my women will come in and they say, it's finally time to take care of me. But she's 80, 85, her heart's failing. What can I do? right? So that at that point, my hands are tied. That's why I beg and I plead. As soon as you can see it, say something about it, come in, let us take care of you. When I first graduated from fellowship, our age of fear was 70 years old. Women after 70, exposure to anesthesia, big risk. And I don't know that that's no longer true, but we are getting better at how we do anesthesia, right? And so now that threshold has moved to 80 years old, 82, 83. It also is important that we now get people out. People go home the same day. They used to spend 2 days in the hospital. 2013 in fellowship, I remember rounding on people for 2 days before they went home and watching for blood clots. So you go home the same day, you're walking the same day, you're lifting 10 pounds the same day. So that return to function is a lot faster. And that has also made it safer to go to surgery. That does not mean that you should wait. It just means that this is the evolution that we're seeing in surgery, which I do think is to our benefit. But we want to be careful once we get past 80 years old. That's a big decision. When we get exposure to anesthesia, and even though, yes, it's dose dependent, we don't know your dose, right? We don't know what is the tipping point. There's no, oh, if she gets more than 3 hours, that's it. Sometimes it's 30 minutes. And then we'll have permanent cognitive decline that we don't get back. So we have to be very careful when we make that kind of decision. Doesn't happen often. In fact, I've never seen it happen in my practice. Knock on all things wood. But I also am very careful about who I take to the operating room, right? I'm very judicious about that. So, okay. No more suffering in silence. That's my quote. All right, well, that's my spiel. Oh, I almost made it, 6:09. All right, so we're going to take some questions here. We'll wait to see if anyone here with us today or anyone in the chat has questions. Oh, yes, go ahead.
Is there a correlation with fibroids and prolapse?
Oh, great question. I do not see as much of a relationship between fibroids and prolapse as I would imagine, because that weight of the prolapse should push down on those ligaments. But I actually don't see as much. It's almost as if you can think of the pelvis as a defined bowl, that fibroid almost acts like a stopper. It doesn't allow the top of the vagina to sink down. That's kind of like the mechanism that comes to mind. But yeah, no, that's a good question.
Prevention.
Yes.
It's too late for me. But I had a hysterectomy, and then I had prolapse, and then I re-prolapsed 9 years later.
Yeah.
Not because of her. I'm new to Portland, so fortunately I found her.
Yes.
But so I'm thinking, estrogen and pelvic floor PT, which I did for 5 months. It's a game changer.
Yes.
It was wonderful.
Yes.
I
yes.
really I tell everybody.
Yes.
And men too.
Yeah.
And that suffering in silence. Let's just talk about
Yeah.
this. My issue is fecal smearing.
Mm-hmm.
I mean, it's
yep.
just,
it's very common.
Yeah. I mean, no amount. I mean, it's just a tiny amount.
Yep.
Any amount
is too much.
It's too much.
Exactly.
And so, and I love to walk, but
yeah.
anyway, when I had it, so my vagina was prolapsing after my uterus prolapsed, but the urologist, a male, told me that I didn't have to use estrogen.
Yeah.
And the gynecologist told me yes.
Yeah.
And he's like, oh, that's ridiculous.
Oh.
So I didn't. And then 9 years later,
yeah.
and now I'm taking it because my doctor and my pelvic floor PT recommended it. But had I been doing that all along, would that have helped prevent a re-prolapse?
Obviously hard to predict, but it would have helped.
It would have helped. I mean, so
it would have helped. Yeah.
Question,
yeah.
Because I've been divorced for 12, 14 years, no sex.
Yeah.
Which is lovely for me. But would this regular sex also help?
Yes, it does. It does.
Contractions
yep.
and all that.
It's a use it or lose it organ.
Yes. I
Nobody tells you that. Nobody tells you that. So when you have intercourse, right, there is a natural rush of fluid to the tissue. So that's an opportunity for revitalization. There's also little tiny micro like cuts and things that happen when we have intercourse. So it promotes collagen and healing tissue, healing cells to come to the vaginal mucosa. So the combination of these things will keep the vaginal tissue healthy. And that is a great question. I have, unfortunately, like there's sometimes we'll have, instead of prolapse, we'll have agglutination where the vaginal walls will start to seal together from not having anything in the vagina for years and years. So.
That would happen to me, the top sealed off.
Mm-hmm. If only you had sex. Well, or vaginal estrogen, right? Vaginal estrogen prevents that from happening.
Yeah, okay.
So.
Well, that's more information.
Yeah. Okay, if you guys want to, I'm gonna allow you. Sorry. We do. Okay, and I was gonna say I'm gonna make it so you guys can unmute yourselves if you want. Are there infection concerns with pest reuse? Okay, this is a really good question. I will say about once a year, I'll have a patient that has a recurring vaginal infection, and it can be from the pessary. It's usually either BV or yeast or both. And we try to balance the pH. And then finally, if it's not responding, we just take it out for a few weeks. And that typically does the trick to kind of reset the flora.
Does that cause bladder infections or yeast
not
infections?
Bladder infections, but vaginal, like bacterial vaginosis or vaginal yeast infections. I have not seen it related to bladder infections. If anything, it'll prevent them because you're emptying a lot more efficiently. You're welcome, Sandy. Okay, let's see. Host tools, participants. Okay. I know sometimes typing is frustrating, so if you want to unmute yourself, you can go ahead and unmute to ask questions too. Okay, we've got another one. How long after surgery using mesh are you allowed to return to lifting previous weight like grandchildren? When I'm like 20 pounds and they're like, oh, she's 25 pounds. I can't lift her yet. 6 weeks. 6 weeks is when, so actually to take a step back, our bodies don't fully scar until about 4 to 6 months after an injury like surgery. So the first 3 months are actually the most critical. And then we've dialed it down to 6 weeks of being careful with our bodies. So at that 6 week mark, it doesn't mean, today go out and run that marathon you've been thinking about, but you do want to work your way back up to that week by week. So I think if your grandkid's 25 pounds, you can lift her as soon as we say go. I think
So can I ask you a question?
Yes.
So, like in my case, when I lift weights, I was lifting 90 pounds and stuff like that.
You were lifting 90 pounds? That's amazing.
I didn't know that wasn't okay.
Yes. So the question is, can she lift weights right now? And in the past, she used to lift up to 90 pounds. And my short answer is absolutely lift.
Okay.
Lift
I
is
haven't done it for 2 or 3 months, so I have to start again with
exactly
60 pounds of
60 pounds. That's where you're starting. I always encourage start with a weight that you're like, this is silly. This is so silly. Like, why am I doing this? Okay. Start with a weight that feels so easy for you.
Oh.
Okay. And then each week, if you're consistently doing that 2 to 3 times a week, then the next week add 5 to 10 pounds. That's usually my golden rule. And then if you have, we've talked about gym memberships before.
Sorry?
Have we talked about gym memberships before? If you
was going to gym,
yeah.
PT.
Oh, you were going to PT?
I was. Then now I've switched to a gym now.
Okay.
But I haven't started with
when you go, oftentimes they'll have a trainer that can kind of show you the ropes and things. So I would say have them give you a regimen. and let them know, like, I'm protecting my pelvic floor, but I want to lift.
Easy with the kettlebells, you know.
Mm-hmm.
I haven't yet tried the
Mm-hmm.
deadlifting.
Are you doing lower body weight training or just upper body?
Just
Lifting things. Okay, so for sure when we're talking about pelvic floor health, as well as balance, decreasing falls as we get older, we want to do lower body strengthening. So anything that strengthens your lower back and your hips are great. And then, of course, legs. And we often forget about hip strength, though. So see if they can.
Classes that they do all these different things. Resistance training.
Yeah, resistance bands, Pilates. I always talk about that, but. Okay, we can talk about that later, but I said we can talk about that later. No, but the trainer is nice because then you're not as beholden to the classes. Like if you want to go on your own time and you're like, if I have 30 minutes and I want to come in and make the most of my time, what are the things I should work on? And that's why it's good to do at least one session. The trainers can be so expensive, but oftentimes insurance will cover a session or two. Or if you're new to a gym, you just act like you're new. And then they'll usually have a complimentary service that where they can show you some things to do.
Are all set in their ways of what they teach. It's not like what you need type of thing so much.
Yeah.
Okay. I didn't have a trainer before. And then I had 4 years of PT, so I was under, you know.
Yeah.
But that was more for my back, not so much for this. So they were kind of concentrating on that.
On the back, did they teach you strengthening for your back?
On my back, yeah. So most
it did strengthening for your back.
I can have to talk to you later. Another day.
I think it is hard to navigate. I'm kind of bullish when I talk to trainers because they want you like buy this package and you're like, I only have 30 minutes to be here. Can I just have one question for you? You know, and then they finally get to it, but you do have to be a little bullish, and so they don't try to sell something to you.
And you think Pilates is
hands
really
down,
like a game changer for core health?
Oh yes.
And pelvic floor. What was you saying?
Pelvic floor, not just the core, but the pelvic floor. Yes. Yeah. Bar is also good. And bar is good if you're not able to get on the floor because they have a lot of standing exercises and chair exercises that you can do, which is nice.
I think of bar as for really young.
Exactly.
You do?
Right.
Oh, okay.
Thank you. Yep.
So do you have some exercises that you recommend for prolapses or what?
I'm not as well versed in that as like Jessica Dorrington, who has studied pelvic floor for 20 years. She's the PT that spoke last month. I usually talk about hip raises and and PT. But if you ever do like a beginner's Pilates class, you will almost immediately realize that you're engaging muscles that you didn't know existed before, which is nice. Right, without holding something. So look for chair Pilates, which is not as common as chair bar. So we like to stay up over the ground. Yeah.
Is yoga helpful?
Oh, yoga is great.
Yeah.
Yoga is great. It always looks so soothing, and you're finishing, you're sweating. But I think Pilates is better because that was designed for muscle targeting. Yoga is good for full body, though, for sure.
These Kegels or something, I don't know.
The Kegels? Okay, so Kegels is a really interesting exercise. You're trying to engage your levator muscles. Your levator muscles. And your levator muscles are the bowl that really coats the inside of your pelvis. And that's where your anal sphincter, your vagina, and the urethra that holds the urine in, that's where it lives. 40% of women on exam cannot do a Kegel, right? You think you're doing a Kegel. In fact, I had a pelvic floor trainer in here. I was like, you're not doing it. And so it's because we feel like we're engaging the levator, but we're actually doing what's called recruiting, where we might squeeze our butt cheeks together. We might even lift off the table, but the actual levators are not moving. Or you'll push when you think you're pulling up. And that's where Pilates is also really good about that. It helps to retrain your mind that when you're pulling those muscles up and towards your heart, it's a really good exercise for that. But there was a study that came out that showed that if you do Kegels by yourself, you have a 17% chance of improving or resolving prolapse symptoms. Whereas if you work with a pelvic floor therapist, it's closer to that 40% that I mentioned earlier.
But I mean, they don't recommend it much because they say, it doesn't do much.
It's a good starting point.
Right, that's true.
It's a good starting point. It also requires some discipline. You're like, oh, I'm at the traffic light, I should do my Kegels, right? And so, but we weren't, before Urogyne became a serious specialty, no one was asking you to Kegel in your GYN exam, right? We were just going in there looking for cervical cancer, which is a good thing to look out for. But we were not doing, pain and tight muscles and looking for prolapse. So, I don't blame them for thinking it was normal because they just looked past it. So, yes.
Back to the Pilates. I know that there are different types of Pilates, like reformer versus mat. Is there a best one?
Great question. So I used to say, you got to go do the real Pilates at a studio if you want to get the most of, the best benefit from Pilates. But in my personal experience, I've realized that if you have a good app on your phone, you can do really good Pilates at home with the proper setup. And the beginner levels kind of just get you used to the exercises. When you really get into it, you can start buying equipment and things like that. And I personally feel like that's a lot more affordable and feasible, especially for the working woman or mother or grandmother who's got a full. My retired women, you guys are busier than me, by the way. I can't get y'all to come in. You're like, oh no, I have dates. I got play dates, but that is a better option if you have a really busy schedule, is to do it at home. And I do see improvement with that.
So are there videos on it or something?
Yes, lots of videos, YouTube. Yeah, if you YouTube Pilates. And I used to have an app that was like $2 a month that did Pilates. So really affordable options out there.
Do you know if there's a correlation between obesity and
I love this question. So, no. With pelvic floor prolapse, we have not been able to successfully draw a line between prolapse and your weight. Now, with urge incontinence, yes. But as far as stress incontinence and prolapse, no, we have not. I wish I could say it was, but it's not. Now, I will say for the surgeries, though, the surgical success rates can be lower if you have a BMI over, if your body mass index, I think, is over 30 or 35, your risk of the surgery failing is higher, but not the prolapse itself.
Is there a way we can access, since I've come late for it, can we access your presentation?
Yes. So our YouTube channel is finally live. Yes. So you can go on there and access the videos. What's that?
How do we know how to access?
Well, for now, we're the only Femme Flôr on YouTube.
So we say there's Femme
For now, just put in Femme Flôr.
I would look up the whole name for women's pelvic medicine.
Yeah.
Because when I look up just Femme Flôr, it doesn't automatically pop up.
Mm-hmm.
But if you look up the full name, there is another video that will pop up. It says Tuesday Talks.
Yeah.
And
So
Yeah.
Femme Flôr, what?
Women's pelvic medicine. Yeah.
Women's health, what?
women's pelvic medicine.
Oh, pelvic, thank you.
Okay. So hopefully Elaine is still on here. Just go on to YouTube and
And that's where we'll access your presentation.
that's where you'll access this whole talk. Yep.
Okay.
Mm-hmm. And oh yeah, that was YouTube.
And so you said older people shouldn't go for surgery. I mean, I don't like surgery. I'd rather go.
Well, you and I have already come. Yeah, we've already come to Jesus about that. We're not going to surgery. And you're doing okay, so you don't need it.
Just to give us a time check. It is
Yes.
6 months.
Okay. It did go fast when you're having a great time. Oh, you're welcome. You're welcome. Yeah, I'm so glad you guys came, and thank you so much. And for everyone that logged on, it does make it feel very worth it. So thank you for logging on. If you have questions, especially if you haven't been here before, you can email us at learnmore@femmeflor.com. And you can also find us on Instagram. Our social media person was just here before. Learn more. It's just our direct email. If you have a question, our direct email account. So learnmore@femmeflor.com. And then we're also on Instagram and we're on Facebook and TikTok.
TikTok too.
Yes, we just got TikTok off the ground too. Yeah. I might be showing my age a little bit. It was a little hard to get that started, but we're on there now. Okay, thank you guys. You guys have a great evening.
Thank you so much.
Yes.
I
For you
look
to give
forward
up your time.